Chapter 19, Respiratory Emergencies. As we've discussed in previous chapters, the primary focus of all of our assessment is ensuring that the patient is going to live. To start off with, we must have an airway. The airway leads to the respiratory system. And so now the next chapter we're going to cover is respiratory emergencies. First, let's review respiration. What is it? It's the process of moving air into the system to have gas exchange at the alveoli level in the lungs. Negative pressure moves air in, positive pressure moves air out. So we change the size of the chest wall. To increase the size, we create a negative pressure inside, sucks the air in. As it relaxes and changes the size back to smaller, it increases the pressure and pushes the air out. Visual representation here. You've got the diaphragm in the relaxed position. As it contracts, it increases the size of the chest cavity, which will decrease the pressure. As the pressure decreases, the air goes in. As the muscles relax, the diaphragm goes back to its normal state, changing the size of the chest cavity to a smaller size, which would increase the pressure inside and cause you to exhale. Inspiration, the active process of getting air into the lungs. You have to use muscles to contract. Diaphragm contracts as the main muscle. You also have the ability to use the intercostals and the neck muscles. Everything can work together. Depends on how much effort you need to get the air in. Once you increase the size, you decrease the pressure, and the air is pulled into the lungs. So this is the active process. The expiration process is passive the majority of the time. You do not have to force air out. If you just relax the muscles, everything goes back to the previous size, increasing the pressure in the chest because you've decreased the size, and air will flow out. So there's no muscle required to make this process occur. You can use muscles to blow out. That's what anybody who's done a pulmonary function test has done, or if you've ever blown your candles out on your birthday cake. Breathing has to be sufficient for life. That's how we define adequate breathing. You have normal mental status. Air goes in and out without any difficulty. You can have a normal conversation. You make your mental status is normal. Your ability to form a complete sentence is normal. You look and act like everything's just fine with your body. You're in normal stasis. Your oxygen saturation is in the normal range. Your breathing rate for adults is 12 to 20. School-aged children, 18 to 30. Infants, 30 to 60. Depends on what's going on in their life, what their body's doing, and how it's reacting, but it changes very drastically depending on what's going on. The rhythm should be regular. With talking and having conversations, your rhythm's not going to be exactly regular, but you're going to still take a normal breath. If you listen to the lungs, everything's going to be present equally on both sides, and you're not going to hear any extra sounds going on in the lungs. So inadequate breathing is the opposite. Breathing's not sufficient to support life. You're breathing too fast or too slow or irregular. And by irregular, we don't mean a breath and then 5 seconds of breath, 6 seconds of breath, 5 seconds. We're meaning they stop breathing for 10 seconds, 15 seconds, and then start breathing again. And then after about 30 seconds, they stop breathing again. We're also talking about inability to speak. They cannot make a complete sentence. They can't form complete thoughts. Or the chest is silent. You don't hear anything at all. There's no air movement in the chest. All signs of inadequate breathing. Low pulse ox. Anything less than 90 at our altitude we get concerned with. Agonal respirations. This is something we learned in CPR class, where the ventilations are occurring every 30 seconds and as a deep gasping breath. It's the body taking one or two last breaths, trying to get something started inside the chest. It's not supportive to life. We're talking about irregular rhythms, diminished or absent breath sounds, or poor tidal volume. They're breathing too fast to get a good tidal volume, or they're not breathing deep enough to get a good tidal volume. Kids, infants and children's airways, just remember they're different. The airway's much smaller, so things get stuck in them much easier. The tongue is huge compared to the rest of the airway. So when we're talking about opening the airway with a jaw thrust or a head, tail, chin lift, just remember the tongue is a little bit harder to get out of the way. The trachea is softer, so if you do hyperextend the neck, you can kink the trachea. And then they are very dependent on their diaphragm to move air. If for some reason their belly gets injured or they have upset stomach and their diaphragm can't fully expand the chest cavity, they won't be taking deep breaths. And then they will be compromised because they don't have the accessory muscles to try to compensate with. We will see nasal flaring if they're having difficulty breathing. Because they are so dependent on breathing through the nose, they will have difficulty breathing, and you'll see it, the nose flapping back and forth. They'll be grunting, trying to force air in and out. You'll see seesaw breathing, so as the chest rises, the belly decreases. As the chest decreases, the belly increases. So it goes back and forth. We also see retractions. So as the intercostals try to help out the diaphragm, they contract, and you'll see that indentation between the ribs as they take a breath. If they have inadequate breathing, you got to breathe for them. And we've talked before on the routes, or the ways we can give the best ventilation. Pocket mask with oxygen, number one option. 2 respirator bag valve mask with supplemental oxygen. And then the least preferred is the 1 respirator with supplemental oxygen. Unfortunately, the one we go to the most in pre-hospital care is 1 respirator with supplemental oxygen. So think about that, and as you gain resources on the scene, try to get another person to help you back. So you have 2 people doing BVM. When you are doing ventilations, you want to watch the chest rise and fall. As soon as it starts to go up, that's when you stop blowing air in. That says you've got enough air going at this one time. Normal ventilation rates 10 to 20 or 10 to 12. Remember, normal ventilations are 12 to 20, but when we're ventilating, we're giving 100% oxygen. We're giving good chest rise and fall, so we don't need to go nearly as fast. So once every 5 to 6 seconds, you give a breath. Be very careful and count out loud when you're doing this, so that we know you're giving enough time between ventilations to let the gas exchange occur at the alveoli level. With kids, because they need a little bit faster metabolism, we do 12 to 20, so once every 3 to 5 seconds. And again, watch for the chest rise and stop when you see it move. In an adult, if the pulse goes up, they are trying to compensate for your ventilations not being adequate. So you need to reassess your ventilations. On a kiddo, if the pulse goes down, it means that you're not giving adequate ventilations. They have a little bit opposite reaction there. So if the pulse changes drastically either direction, think about what's going on and try to make sure that you're doing adequate ventilations. Make sure you've got oxygen hooked up, you're doing the right speed, and you are giving the chest the appropriate rise and fall options. For difficulty breathing, they're adequate, but they are having some problems with the perception of their breathing. They feel like they can't get a deep breath. They may be labored. They may be looking like they're distressed, but it's not quite in the inadequate phase where we're going to have to breathe for them, but we want to catch them now and help them out. You walk up and you see this patient sitting in the tripod position. He looks anxious. His lips are kind of blue. His skin's kind of pale. He looks like he's having difficulty breathing. So we're going to assess that patient and try to find out why they're having difficulty breathing and what we can do to fix it. So first we're going to talk about the onset. When did this happen? What were they doing? What caused them to be this way? What makes it better or worse? What provocation do we have? Quality. How does it feel? Do you cough? Is there anything that you cough up? What does it look like? How much of it are you coughing up? Does it go anywhere else? Does it spread to any other parts of your body? Anything else hurt? On a scale of 1 to 10, with 10 being the worst trouble you've had breathing before, how do you match? And that's going to help us assess whether we're treating them correctly because we can see a decrease or increase. And how long has this been going on? Look for their mental status. If they're not alert, document what's going on, whether they're confused about person, place, and time, whether they're only able to respond to your question with nods or grunts. Look at their body structures. People that have chronic obstructive pulmonary disease typically have a barrel chest because they've had difficulty breathing for so long. The body adapts and the chest looks kind of round shaped. Look at their body positioning when you walk up. Are they tripod position, leaning forward? Is the neck jutting forward, trying to open up the airway? Do they have their feet dangling, kind of leaning forward, trying to get the blood or the fluid to pool in their lower extremities so they can get off the lungs? Look at how hard they're breathing. When you're talking to them, listen to what they say and how much time it takes for them to say what they want. They're breathing inadequately. Look at their lips. Are they pursed together? Are they trying to keep that back pressure in the lungs so they can breathe adequately? Are they using extra muscles as they breathe? Look at the skin. Is it pale, cyanotic, flushed? What is going on with their skin? Look for edema. Either in the lower legs, if they're sitting up, having their feet dangled, you'll typically see the edema in the lower legs, or maybe in the lower back. When you push on it, it looks like a Tempur-Pedic mattress, and you leave your fingerprint, and it takes a few seconds for that to actually refill with fluid. So that tells you it's edema in the interstitial area. Look at their pulse ox. Anything less than 95, we get a little concerned with. Anything at less than 90 at our altitude, we're really concerned. So looking at this guy, the first clue you see that he might have respiratory problems is he's already wearing oxygen when you get there. That's a big clue for you. And you see that he's kind of thin and his chest is kind of round shaped, kind of barrel shaped there. Look at his nose. Listen to his coughing and look at whatever he's coughed up. Does it look like there's anything in there that you want to note? Listen to his lungs. What do you hear inside? Look at his muscles as he breathes. Do you see any extra effort there? Listen to the breathing. Upper airway, if you just walk in and you hear audible wheezing, that's a clue for you. There's problems going on. You hear gurgling or snoring or stridor or coughing. Those are signs that you can pick up as you walk into the room and as you start talking to your patient. Once you get to this point where you can listen to the lung sounds, you're going to listen all 6 quadrants. You're going to have 2 upper, 2 mid-axillary, and 2 lower. So you can listen to all 6 locations there. Here's listening to the lower back. You need to pull up the shirt or put your stethoscope under the shirt. Good patient care says you should warm up the diaphragm of your stethoscope before you do this. So either rub it on your shirt or keep it tucked in your coat or in your shirt, somewhere that's keeping it warm so you don't cause more stress to your patient. As you're listening, you're looking for wheezes, high-pitched squeaky noises as air go through the bronchioles that are filled up with mucus or something, the kind of squeaky. Crackles is a bubble as you get fluid down the alveoli, and as they open and close, they smack on each other. So that it's kind of like, sounds like someone smacking gum inside their chest, but it's real fine crackle. Bronchi are the kind of rumbling you hear as the air vibrates through the constricted airways. So that's lots of secretion in the lower airways, and you hear that little rumble as it goes through. Stridor is that squeaking noise is something stuck in the upper parts of the airway. So as it pushes by, it kind of squeaks for you. So assessing, you're looking for changes in your vital signs too. Look for abnormal pulse. High or low are signs there's problems with the breathing. Look at the change in the rate and the rhythm. Maybe it's getting better. Maybe it's getting worse. Look for changes in the blood pressure. If they're having obstructive issues in the lung tissue, the heart's going to react and they're going to increase the blood pressure. If they're having difficulty getting enough perfusion to the end organ, you may have hypotension. Maybe it's not getting enough oxygen to the heart to actually give good contractions. So pay attention to what your vitals are telling you. If you're assessing your patient for difficulty breathing and you're not confident that they're having good ventilations, that they can't suck the oxygen in on their own, you're going to have to provide artificial ventilation for them. Preferred, if they are conscious, you look at some alternatives before you go to this. But if you have to, you go to artificial ventilations. If they're breathing adequate, they have the ability to suck air in. They just don't have the ability to use the oxygen that's there. Give them some more. Give them a non-rebreather by mask at 15 liters or nasal cannula up to 16. So give them a little extra oxygen because we know they can pull it in, they just can't get enough out of it. Set your dosage based on what your protocols are. My preference is 15 non-rebreathers, 6 nasal cannula. That way you don't have to go back and forth and try to figure out. Put the position in their positional comfort. Ask them if it's more comfortable to sit up. Maybe they want to keep their legs dangling over the side of the cot. As long as you can secure them to the cot so they don't fall off, you can set them however you want. If they have an inhaler, you can administer that. If you have albuterol in your protocols, you can administer that. You can do a CPAP. You've got lots of options as an EMT to help clear up those airways and maintain a good ventilatory system for them. So CPAP, continuous positive airway pressure. What we're looking for is a back pressure into the lungs. So as they exhale, it's putting about 10 millimeters of mercury pressure backwards into the lungs, which keeps the alveoli open. It keeps the fluid from filling in those air passages as we exhale. So it keeps that backup from coming in. Now this can cause some problems with your heart, so that's why we're going to have some precautions as we do this, but the heart doesn't function if we don't have air, so this is a high priority here. We use it for pulmonary edema primarily. Somebody has some type of edema, usually caused by congestive heart failure, or it could be some type of chemical exposure or drowning. Asthma or COPD, a chronic condition that causes difficulty breathing, or they're just having some bad respiratory problems and we're not sure what's going on, but they can breathe on their own. They're just not effectively getting it deep into their lungs. So this will help with that process. Contraindications, severe mental status changes. If they are unable to maintain their airway, they're unable to use a CPAP. Lack of normal respirations, and they have to be breathing for this to work. They have to be sitting up in a Fowler's or semi-Fowler position for it to work. They can't be supine. And then they need to have good perfusion for the air to move or the oxygen to move around once we get it in there. So if they're hypotensive, we don't use this. Other contraindications are nausea or vomiting. We do not want to strap a plastic mask over their face while they're vomiting and block their airway. Bad deals there. Chest trauma. I do not want to increase the pressure in the chest if I've got a hole in the chest somewhere. Same with shock. I don't want to increase the pressure in the chest if I'm trying to get blood flow to move through. It's not going to help out. GI bleeds or gastric surgery because I could actually put some extra air into the stomach. And some reason they can't get a good mask seal. Remember, we're using a full face mask for our CPAP, so they need to have fairly close shaved face hair. They can't have any facial injuries. If they have a stoma, probably don't want to put a CPAP on them. You need to be able to get a good mask seal so they can get air in and out of their oral pharynx without any difficulty. Side effects you're going to run into is hypotension. You could blow a lung. If you have too much pressure and they've got a weak spot in their lung, it could actually cause a pneumothorax. You increase your risk of aspiration because you can't see their airway as well. So if they do vomit, it could go back into the airway. And then the side effect that they'll just have to live with is the drying of the corneas. Because this is a full mask, it sits right on the bridge of the nose. If there is a leak, it will typically be at the nose bridge, and then it'll blow across the eyes and dry out the corneas. Very important, when you start this process, tell the patient who is already feeling like they can't get a deep breath why you're going to strap a mask over their face. They will probably be anxious because they're hypoxic. They're concerned that they can't take a deep breath and you want to stick a piece of plastic over their face. Probably not the most calming process you can do, but as long as you can explain it to your patient and tell them what's going on, they will be much better off with it. When you do put it on, you start with your 10 millimeters of mercury to wake your way up, but follow your local protocols on that one. Here's trying to set up the patient to make him understand what's going on. He's really anxious. He's not sure what's going on. He wants to breathe, and you're going to put this mask on his face. So have some good conversations, get a good rapport with your patient, and your mask, and make sure everything's set up right. Reassess as you do it. Continually reassess. If it doesn't get better, increase your rate or your pressure. If you start at 10, go to 15, go to 20, go to 25, go to 30, whatever your protocol allows you to do. Continually reassessing the vital signs, making sure you're not having any hypotension, the patient is doing good, and they're not having nausea. Patient gets worse, take the mask off and start ventilating for them. They vomit, take it off suction. The patient has gotten worse on them, and they're taking it off and moving over to the bag valve mask. All right, some chronic respiratory conditions we're going to run into. Chronic obstructive pulmonary disease. This is a category where we throw in emphysema, chronic bronchitis. Lots of chronic diseases that we need to help assess our patients. These are patients that live with us every day. Something went wrong, and they ended up calling 911 today. Majority of these are caused by smoking. They're caused by smog, environmental toxins, working situations where they've been exposed to asbestos or black lung disease from coal dust. So there's lots of causes. We're not really here to figure out what caused it. We're here to provide the treatment. So chronic bronchitis is an inflammation of the bronchioles. Lots of mucus in there. It's hard. These are the people that wake up every morning and just are coughing up a lung, it sounds like. So they're trying to get rid of that mucus and get everything cleared up. You see on this diagram, you've got the normal alveoli over here. As you get chronic bronchitis, this mucus goes down in the alveoli level and causes these alveoli to get filled up with mucus plugs, and that's a problem for us, so they can't take a deep breath. The next disease we're going to talk about is the chronic emphysema. These extra surfaces start to disappear and the alveoli get more rigid, so they can't take a deep breath. So that's the other side of COPD. The walls break down, you have less surface area to gas exchange. That's when the patients get that barrel chest because they're using the accessory muscles to try to get the air in and out. because they have a hard time squeezing the air out, they maintain a higher level of carbon dioxide. When they have that extra level of carbon dioxide in their bloods, their carboxylic drive gets overwhelmed and starts to stop working. That's when we rely on the hypoxic drive to take a breath. Asthma. This is a, a category of anaphylactic reactions. It's a chronic problem with the lungs when they get exposed to certain toxins or certain stimuli in the environment. You get an overproduction of mucus, and the bronchial tubes get narrow. So they have difficulty breathing, they have an asthmatic attack. Asthma is restricted in one direction, so they can take a breath, but they can't exhale. So the lungs can pull air in, and it's trapped in the lungs. They need some type of medication to relax the bronchioles so that you can increase the size and let the air pass that extra mucus that's being formed in there. Pulmonary edema. You've got lots of fluid in the alveoli. This is mainly caused from congestive heart failure. It can also be caused from chemical exposures, but somehow they're getting lots of fluid built up in the lungs. It's basically drowning in their own fluids in their body. You get pressure buildup on the pulmonary capillaries. The fluid actually crosses the membrane in the alveoli and starts to accumulate. The patient is dyspneic. They have their blood pressure actually starts to rise on this occasion because they're trying to push the blood through the lungs, but there's all the extra fluid to keep it from going. Symptoms we're going to run into: dyspnea, anxiety from the hypoxia, pale sweaty skin. The anxiety is causing the release of epinephrine in their body, which is causing tachycardia and hypertension. Respirations are labored and rapid because they're trying to get as much air in and out as possible, but their O2 sats are low. They're not doing the job. People that have a really acute case of pulmonary edema, you can hear it when you walk in. You hear wheezes, crackles. They're coughing up pink, frothy sputum. Looks kind of like egg whites that are pink, kind of frothy looking there. So look in the trash can, look in the spit bowl beside them. They've all got it sitting there ready for you to look at. Treatment: lots of oxygen. Keep them in a position of comfort, which is typically seated, maybe even leaning forward in a tripod. And the cure-all treatment for this one that EMTs can apply almost immediately is CPAP. CPAP uses that back pressure to push the fluid out of the alveoli back into the vascular system and help with the actual gas exchange there. Pneumonia. We have infections from bacteria, viruses, fungi. Some type of microbe gets in there and starts to grow and cause inflammation. The biggest cause of death for geriatric patients is fracturing a hip, going to the hospital where all the other sick people are, and catching pneumonia. So it's not the immediate trauma, the acute situation that causes the death. It's the infection from being in a hospital filled full of sick people. So we need to start sending our old people to places that there aren't filled full of sick people. Signs and symptoms: shortness of breath, coughing, fever, and chills. This is the one where you've got an infection, so you're starting to get that fever, and it hurts when they breathe because it's pushing through all that infected tissue in the lungs. And headache, pale, sweaty skin, fatigue, confusion, all signs that they're not getting good perfusion to the brain. Treatment: keep them comfortable. It's possible to put CPAP on it, not always optional, or it's not always the first option, but just give them oxygen and get them to the hospital. If you think it may be some type of contagious airborne disease like COVID, make sure you put a mask on your patient and a mask on you and protect yourself. Spontaneous pneumothorax. Trauma, we talk about pneumothorax from some type of exterior trauma that causes a hole in the chest wall and allows air into the pleural cavity. This is a collapse of the lung based on a interior pneumothorax. So the lung tissue actually springs a leak and leaks into that vascular system. These are typically people tall, thin, athletic looking most of the time, but they have a history of COPD, smoking, lots of coughing, and they just pop a lung and it fills up the void from the inside out and causes that pneumothorax. They'll have sharp pleuritic chest pain. They can very pinpoint. They can tell you exactly where it hurts. Shortness of breath. They're easily tired. O2 sat is low. Fast breathing, tachycardia. They won't have lung sounds on the side that's collapsed. So that's a clue there for you. They don't have any history of trauma, but they act like but they're showing a pneumothorax, so it's probably a spontaneous one. Treatment: call ALS. If it becomes a tension pneumothorax, ALS does have some corrective actions they can do. They can either stick a needle in the chest to release the air, or some services are actually practicing finger thoracotomies, where they cut a hole in the chest and they put their finger in and try to relieve the pressure. Definitely for EMTs, you can give oxygen or do not give CPAP. CPAP would not work because you don't want to increase the pressure in a lung that has a hole in it. And then rapid transport. Pulmonary embolism. Somewhere in the body formed a clot that broke loose and went to the lungs and actually got stuck in one of the pulmonary veins or arteries. So that's what we're concerned about, is getting that clot in there, causing a problem where they can't get the blood flow through the lungs, and it stops your respiration at the alveoli level. People that are sitting down in the same position, so long flights, sitting in traffic on I-25, sitting in a Quentin Tarantino movie that's 3 hours long, things that keep you from moving. Active cancer, because of the cancer treatment and all the various drugs and chemo they're giving you, it can cause that clotting factor to change in your body, or even as simple as having a body part in a cast for too long. That's why they try to do flexible cast now and do physical therapy with you as soon as possible, so we don't get these deep vein thrombosis. Signs and symptoms: pleuritic chest pain. They can pinpoint it just like the pneumothorax. Shortness of breath, anxiety, tachycardia, tachypnea, pain or swelling in both legs if it's a DVT that came from the legs. And unlike the pulmonary edema, pulmonary embolism, you're hypotensive and could even go into cardiac arrest. Treatment: oxygen and drive fast. Get them to the hospital. Epiglottitis. This is caused by swelling of the epiglottis. Epiglottis is that little flap that sits on top of the trachea that keeps the food from going down. If that gets infected, then we have some issues trying to get the air to go past it. Because it's enlarged, because of the infection, you're going to have a sore throat. It's going to hurt to swallow. They'll be in a tripod position. These are typically kiddos, and they're going to have just that sick look. They don't talk very loud because the air has to go through the vocal cords, which is at the top of the trachea, and the epiglottis sits right on top of that, so they're real careful about how they talk. They may have some drooling or stridor. Treatment: keep them calm. Do not reach in the throat and check anything out. Do not put an OPA in. Lots of oxygen, maybe humidified if you got the option, and transport. Croup is a viral infection of the larynx, trachea, and bronchi. The epiglottis is the very top. This one gets down in the trachea and the larynx. So it's going to be restricted. They're going to have hard time swallowing and breathing. They'll have this one is kind of triggered or differentiated with a seal-like bark. So they'll kind of bark or squeak when they cough. Very hoarse voice because of the swelling, difficulty breathing, inspiratory stridor because of the swelling of the trachea. Do ventilations if you have to. Give them oxygen for sure. Call ALS. ALS can actually give a nebulizer with epi in it to kind of relieve the pressure there. Lots of oxygen if you need to, and keep them in a position of comfort. Bronchiolitis. Small airways become inflamed with some type of viral infection. RSV. This is a common occurrence in kids, and the problem with it is it's very contagious. So you have a family of kids that get sick at the same time. Very cold-like symptoms, so it's hard to differentiate. They get worse real quick. Uh, like I said, multiple kids getting symptoms at the same time, and you treat very rapidly because it can get bad on you. Artificial ventilation if necessary. So if the kid quits breathing, you breathe for them. Give them oxygen. Clean the nose out as much as you can. Every time a kiddo gets sick, his nose gets stuffed, so use a bulb syringe or something to clean it. Just a simple act of clearing the nose, you can increase their ability to breathe. Cystic fibrosis is a chronic genetic disease. It's a thick, sticky mucus in the lungs and digestive system. That's what we're talking about on this one. If it gets too thick and it blocks the airway, they can have difficulty breathing. The caregivers typically know what's going on, so they're the ones that are calling you to tell you there's a problem. They're coughing up large amounts of mucus, they're fatigued, coughing up blood, nausea, weight loss, all the real serious signs of difficulty breathing. So ask the patient or caregiver, what do you need to do? They will tell you, I need to be suctioned more, or I need to have oxygen applied. They typically know what's going on. So do what they ask you to do. Other viral infections, 17 billion people each year get some type of viral respiratory infection. If you haven't heard of a viral respiratory infection in the last 18 months, you haven't paid attention much, because SARS, which is one form of SARS, is COVID-19. So you should know all about respiratory infections that are viral format. So symptoms: scratchy throat, sneezing, watery eyes, fatigue, chills, fever, shortness of breath, coughing up pink yellow sputum. With the COVID virus, we're actually adding in loss of taste and loss of smell, but very similar symptoms right here. Treatment, oxygen, and transport. The biggest thing with the COVID infections is we need to protect ourselves as much as we protect our patients with any respiratory disease. So put a mask on them, put a mask on yourself, and use good hygiene and clean up after everything. So here's some of the treatments we can do for breathing issues. Not treating the breathing, but treating the breathing issues. Prescribed inhalers. We have a meter dose inhaler that the patient has. They have determined how much medication they need per squirt. So they squeeze the inhaler, they get one dose. Most of these times it's for bronchial constriction, for asthmatics or chronic bronchitis or acute bronchitis. They've been given the inhaler. A lot of times they're not sure how to use it or if they should use it, so that's why we have the ability to help them with that process. So an inhaler goes in the mouth, you squirt it in, they hold it in their lungs, and the medication's absorbed. Before you use it, make sure you have your 5 rights: right patient, right time, right route, right medication, right dose, right route. Check the expiration date and make sure it's not out of date. Shake it and make sure it's warm. If for some reason the patient that needs the inhaler is having difficulty breathing, that should be a Captain Obvious thing for you, they may need to have a spacer. We typically carry those on the ambulance, or the patient may have one of their own. So you check the 5 rights, got that down. Here's the spacer. Spacer is an aerosolizing chamber, so you can squeeze the inhaler, it pushes the medication into the spacer, and then the patient who is having difficulty breathing can breathe as deep as they can, and for the next 30 seconds to a minute, the medication can go in their lungs. So if you have a patient that needs an inhaler, you have them exhale, put their lips on the inhaler or the spacer, press the inhaler as they inhale deeply. So you tell them to take a deep breath and you squeeze it. Tell them to hold the breath as long as they can. You can do that 2 or 3 times with the spacer in. So have them take a deep breath and hold it, and have them take another breath and hold the breath. We do not want to give them more than the recommended dose based on the prescription on the inhaler. So we use what their doctor has prescribed. Small volume nebulizer. If they do not have an inhaler or it's not working, we can go to a nebulizer and give them albuterol. Albuterol is the main drug we use for our inhaler. There are other drugs that ALS will use, but the process is all the same. You put oxygen, run it through this device, it nebulizes the medication that's in the chamber, and they breathe it in nice and slow and gets into the lung tissue where it's absorbed. Gives a patient also extra oxygen as they're doing this process. So you can see on here, it's got the chamber underneath the hand. That's where the medication is. You're nebulizing it into the tube, and the patient is breathing through the mouthpiece just like normal breathing. So as with every chapter, if you have questions, write them down and bring them to class. Thanks, and have a great day.